So welcome to the last of our webinar series. We have here Dr Olivia Hum, who is an experienced GP and one of the small number of British Menopause Society recognised menopause specialists. And she spent years seeing women of all ages, not just about the menopause, also about sexual health, contraception. So she's got 15 years of experience. So we're very lucky to have her here tonight, going through the things that we all want to hear about. So I will hand over to her. She's going to go through the presentation, and then we'll see how long we've got towards the end for you to ask questions.
So I've called this menopause, it's not just hot flushes, and that's because, as comes up on the forum regularly, as we all know, so the only symptom which a lot of doctors seem to recognise as being menopausal is hot flushes, but actually, as we all know, it's all really different now. And this is sort of part of this is looking at the journey that what has happened to HRT and menopause over the last 15 years since I've been a GP. So when I started, what we were doing is that's when the big trials came up that were about breast cancer and HRT. And suddenly as a GP, we were taking everyone off their HRT. We were sort of calling women in. We were telling them to stop taking it. And women didn't want to take it either. So people who were having terrible symptoms were still coming off their HRT because they didn't want to take it. And so then everything went quiet for about 10 years or so. And definitely for about 10 years as a GP, I hardly saw anyone who wanted it. And so women just didn't want to take it. They were scared. The media was really anti-HRT. And then suddenly, literally in the last year or two, things have started really, really changing. And so suddenly GPs are having to sort of upskill massively. Obviously, there's been quite a lot going on in the last 2 years as well. And so a lot of women are finding that they're not getting the help that they need. And so about 4 or 5 years ago, I started training as a thing called a BMS Menopause Specialist. And I do a lot of menopause work, both on the NHS and privately. And so this is what we're going to go through today. So because it's often there's a little bit of confusion about what the menopause actually is. So people will say, so where am I in the menopause? You know, am I through the menopause? So, and we'll look at what it is. We'll look at why this is such a big issue, and look at the symptoms, which is what we all want to know about, and looking at a bit about how we can help symptoms without HRT, looking what HRT is, looking at sex, contraception and libido, and then talking about a little bit about breast cancer. So the menopause actually literally is just your last period. So it's not actually, it's what we talk about in some medical terms is the menopausal transition, which is from the perimenopause, which is when you first start noticing changes in your body, and then till 12 months after your last period. So you don't know when you're going through when you have hit your menopause, because you don't know that you've had your last period until 12 months after it. And the other thing to know is that you often don't know that you've had your last period, because like many of us, like I have a Mirena coil, so I don't have periods. A lot of women are on the progesterone only pills. So many people will never know when their menopause is. So you just have to go by symptoms. The average age in the UK is 51, but you can start going through the perimenopause a lot longer before that. And so this is why it's such a big thing. So definitely up until a few years ago, and you know, even now, I think, and still in a lot of people's minds, the menopause was this slightly comedy idea that like, oh, isn't it terrible? You go through menopause and you start feeling a bit stabby and you hate everyone and you have hot flushes and you lose your shit at work and you can't do anything properly. And the problem is with this is that it's sort of all caught up with all this real misogyny that women in their 40s and 50s are sort of nearing the end of their useful life, and we're all sort of coming to the end of it now. So the fact that we've sort of turned into these slight comedy figures, sort of entitles our husband to run off with his secretary who's 22. So the fact is that this is the way that it's been seen, and the fact is that women in their 40s and 50s now don't want to be characterized like this. You know, we're not sort of funny cartoon comedy postcard characters. We are women we want to have relationships, we want to be having sex, we want to be working, we're incredibly professionally important, we're often juggling enormous amounts when it looks at children and households and elderly parents, and we need to be able to function in order to get through this stage in life. So we're just not ready to be written off. And so this is why, so if you look at these stats, so there's some of them are really, you know, really striking. So 50% of women feel that the menopause has an adverse effect on their life. Many feel it's affected their work. And a lot of never to see a health professional, although I think this is hugely changing, given what's happened to me in the last sort of 3 or 4 months and to other GPs on forums that I'm on. Luckily, women are beginning to come forward and say, I'm not putting up with this anymore. I just want to feel better. But a third of women who went with menopausal symptoms symptoms were not offered HRT. And if you think about it, we now spend a third of our life postmenopausal. So it's a long time to be without estrogen. And so we can't, unfortunately, discuss hormones without looking at this terrible diagram. So this was one at a medical school that we all learn and then forget the day after the exam. It's really difficult, but it's good at sort of working out what's going on in your cycle. So your cycle, so day naught, so that is the beginning of your cycle. And then what happens is your estrogen level goes up. And that's why in the perimenopause, quite often you'll feel fine in the first 2 weeks. In fact, you feel great. You just, you've got loads of energy, you feel fantastic, you're nice to everyone. Then suddenly you ovulate and then your progesterone starts. And for a lot of women, what happens in your 40s is you start getting much more sensitive to your own hormones. So your progesterone time of the month, you will start feeling really just bloated and tired and angry and weepy. And then suddenly, and as you can see, well, the key thing to look at is what happens to your estrogen. So as you get to day 24, 25, 26, 27, your estrogen level is dropping and dropping and dropping. And so a lot of the women I see in their perimenopause will start getting menopausal symptoms. They'll start getting hot flushes, they'll start not sleeping, they'll start wanting to kill everyone. And this is at the end of your cycle. And that is why it's happening. And so you can understand it when you look at the hormones. And the other thing to realize is that estrogen is everywhere. So it's produced mainly by your ovaries, but it also affects practically every part of your body. And this makes sense. This is why the lack of estrogen causes so many symptoms. So this is what happens in the perimenopause. So lots of different things happen. And so what happens is you may well be still having cycles, but your estrogen levels are beginning to go all over the place and they're beginning to rise and fall. And that's why you'll have some days when you think, it's fine, I don't need to see anything about this. Or I must have just been a bit stressed last week. And then you'll suddenly then feel much better for a little bit and then you'll feel worse again. So your periods might become irregular, or they might stay completely the same. And the key thing to know, and this is often brought up on the group, isn't it, is that blood hormone level tests may be normal. So there's no point in testing your hormones in the perimenopause because actually they vary so much that you could be fine one day and abnormal the next day. No one really knows what normal is in the perimenopause. But the other thing to say is that you can still get pregnant, which is really important to know because a lot of people, it's the time when you start slipping up a bit with contraception, and a pregnancy in your late 40s, if you don't want it, is pretty devastating. So there we go. So these are the symptoms. So this is sort of composed of the symptoms which I see most of. And so about 80% of women allegedly will have some kind of hot flushes, but I think that's sort of studies looking at postmenopausal women, while a lot of the women we're seeing now are perimenopausal. And so for a lot of people, actually, it's not the hot flushes that are the problem. It's the insomnia and the irritability and the brain fog. And those are the things that it's what we call the cognitive symptoms, the symptoms affecting your brain that really, really worry people, because these are the ones that make you unable to function. So not being able to sleep and then having to get up and deal with children or deal with a presentation at work and or feeling anxious all the time. So a lot of women will say to me, I've never felt anxious before in my life, but suddenly in my mid-40s I'm anxious about everything. Specifically driving seems to be a massive thing. I'm anxious about driving, going to new places, especially kind of combined with lockdown. People are getting a lot of social anxiety. And the key thing for me that distinguishes this from normal primary mental health problem is that these are often women who have never ever suffered with this before. And that is so the other thing is women who have suffered with anxiety before often find that it's worse, or that it's different. It's just different from their usual anxiety. And then there's a massive list. So joint pains, so Jackie's talked about that in her webinars, is a classic one. But again, there are lots of other things we can do about joint pains, but that is a fairly classic thing in the perimenopause. Fatigue is a really big one. And then there's all the vaginal symptoms as well that I'll talk about that often women ignore because they feel that that's just what they're meant to put up with. So painful sex, vaginal dryness, and the other things are things like loss of libido. So many women that I see have already seen other specialists and they've already been started on other medication, especially as comes up again and again and again on the group, is antidepressants. So these are your ways of looking at treating your menopause without using HRT. So a lot of women that I see have in the perimenopause are trying to avoid taking the hormones for as long as possible, which is absolutely fair enough. And these are made by my friend Karen Newby. So if you follow her on Instagram, she's fab. She's a nutritionist who specializes in women's health and menopause. And she's really, really brilliant at not being, she's all about the evidence. She's not about taking loads of supplements, although there are some that she recommends. She's about food and about getting, just reducing your stress levels, reducing your caffeine, reducing these sort of sugar ups and downs that you get in the menopause because you're tired and you crave sugar and then you get a crash again. And just thinking about hot flushes and how to manage them. So avoiding the stimulants. Often people find like caffeine and alcohol will generate them. And we know there's good evidence that eating a diet in whole grains and vegetables and unprocessed food does actually improve your menopausal symptoms, as does exercise. And that's really a lot of the women I see. So I live near the sea. A lot of the women I see swim, which really, really helps them with their menopausal symptoms. But there's all sorts of any exercise. And the other thing to say is, and again, I know Jackie's talked about this, is the type of exercise you need to do changes. So a lot of people are sort of really caning up on the cardiovascular exercise and not losing weight. It's all about sort of knowing that your body is changing and doing things like yoga and resistance exercise instead or as well. And then these are the non-hormonal actual treatments that we use. So a lot of these are used by women who had breast cancer who can't take HRT. The supplements that people have told me work are sage for hot flushes, and magnesium for sleep is really popular. So I know quite a lot of, on my doctor's menopause forum, there's a fair amount of them who take magnesium. There are some medications we can prescribe for hot flushes, which are they all have side effects, unfortunately, but some of them can be really, really good. And then St. John's wort, which is a very mild sort of herbal anti-anxiety antidepressant. And then the other thing is these plant-based estrogens and soy, which can help relieve the symptoms. So then we come on to HRT. And so this is the biggie. And so then these are the myths about HRT. So I could go through about 40 of these, but these are the ones that I hear mostly. So what people are worried, and these are what women are worried about and what they tell me again and again. And the first thing is that people worry that they're going to feel worse on HRT. And these are especially women who've been very sensitive to hormones in the past. So women who have really bad side effects on the contraceptive pill, who have terrible premenstrual symptoms, who are very sensitive to progesterone. And they often find, and so that is where it's really good seeing it. So when I see them, we can often sort of play around a little bit with the different types of hormones that we give to try and make the symptoms get better. But the key thing is that if you've been sensitive to the pill, those are artificial hormones, and the HRT, which we talk about a lot on the Facebook site, is the body identical or the bioidentical hormones. And the good thing about those is they do not have the same side effects. So a lot of women who've been awful on the pill do still manage to take HRT. Jackie had a question for you about delaying the menopause, so we'll talk about that afterwards. But yeah, it's a myth. It doesn't delay the menopause. People worry that they'll never be able to come off it again, and that's not true, actually. Usually when women want to stop, they do manage to stop. Breast cancer we'll talk about later. And then the other thing is that, and again, I think this has usually changed even in the last 2 or 3 months. So 2 months ago, before Davina, a lot of women were coming in saying, I don't want to take HRT because I feel really bad about it because my friend's never taken it. She says that she just went through it with a bit of sage, and so there's this whole idea of this thing of women having this, we all feel that we need to cope, and it's a big thing for women. I think we have to cope with so much, we're juggling so many different things, and there's this idea that taking HRT is somehow giving up, is you're giving in, you're not coping. And again, and often women are worse at sort of shaming other women for making the choices, and in the way that sometimes we use the word natural to sort of beat other women with a stick and say, well, oh, you had a cesarean, did you? I had a natural birth. And that's absolutely fine, but to feel proud if you've done things naturally, but it's not fair to make other women feel bad about it. Because quite frankly, some women sail through menopause with a bit of herbal tea, and that's absolutely fine. And it's really great for them that they've managed it. But other women feel absolutely dreadful. And I've seen women whose lives are just completely ruined by their menopausal symptoms. And quite frankly, denying them the chance of taking a medication that's going to make them feel better is just not very nice. You need to be supporting each other, I think. And then the other thing that's the real bugbear of any menopause specialist is the I've been told I can't have HRT crowd. And again, that comes up again and again and again on the forum, doesn't it? I can't have HRT because of all sorts of different things. So this is the list of people who can have HRT. So nearly everyone can take it, especially the transdermal HRT, the HRT through the skin. There are only a few people who can't have it ever, or almost never. So anyone who's had an estrogen-dependent tumour like breast cancer, we can give you HRT, but that is a big deal, and that would involve a discussion with a menopause specialist and with your oncologist, and a sort of really big risk-benefit discussion with you about the risk of recurrence of your breast cancer. Anyone who's got abnormal vaginal bleeding, it needs it diagnosed first before we start you on HRT. And then there are a few medical conditions that if you're actively having a heart attack at that moment, you cannot have HRT, but after a heart attack, you can. And then the key things that people are always told, you can't have HRT because your periods haven't stopped. Well, we know that's not true, don't we? You can't have HRT if you have endometriosis. That's not true. Breast cancer in your family, I'll talk about a little bit. And the other thing is you can have HRT if your blood tests are normal. The other things that commonly come out, you can have HRT if you've got high blood pressure, and you can have HRT if you are overweight. So this is my simple 4-step guide to thinking about HRT. So step 1 is estrogen, and this is the good stuff. This is the stuff that relieves your symptoms. Some people take the tablets, and that's absolutely fine unless you've got other risk factors. So if you're overweight, if you've got high blood pressure, you shouldn't take the tablets. They're much more risky. But the skin, via the skin, is safest, and that is the gel or the spray or the patches. And that's the estrogen, and it's the one that most people take on the group is Estrogel, which is the pump pack. And you take a pump and you rub it on your inner thigh, and then you smooth it on, and then you sort of fan or pat it so that it absorbs. And that's great because you can adjust the dose really easily without having to go back to your GP. Now, and this is what causes the most massive amount of confusion, is the progestogen. So progestogen is an artificial form of progesterone. So everyone who's got a womb needs to take a progestogen or a type of progesterone, and that is not for your symptoms. That is simply to protect your womb. It protects your womb against the estrogen. So if we gave you estrogen on its own, your womb lining would grow uncontrollably. And then you'd start bleeding, and eventually you might get cancer of the womb. And in the very early days of HRT, in sort of the 60s, that is what used to happen to women until they realised that you have to protect the womb lining. And there are 2 ways of taking it, and this causes enormous amounts of confusion. And I think it's probably because quite a lot of doctors don't understand it either. If you've had a period in the last year, you only take the progesterone for half the month, and then you have a sort of artificial period every month. And the reason why is because if you've had a period in the last year, you've still got lots of womb lining around. So for the first year or so of taking it, you need to be shedding that womb lining every month. Otherwise, what will happen is that it will just grow and you'll start bleeding all over the place. It won't be dangerous. It will just be really irritating, because then you have irregular bleeding. And then you're like, well, do I need a scan? Have I got cancer? And then you've got to go through all these tests. So if you've had a period in the last year, for at least a year, we need to put you on sequential HRT, which is a period every month. If you haven't had a period for over a year, you take it every day. And that's because we assume now you've got no womb lining left. So you just take a little bit of progesterone every day, and you shouldn't have periods. That's called continuous HRT. And the one that many women love now is the micronode progesterone, the Utrogestan, which we call body identical HRT. You can get combined tablets and a patch. And then there's also the Mirena, which a lot of women, I know there's been a lot of bad press about Mirena over the last few days. So I put in Mirenas, and I can tell you that the vast majority of women, it goes in with absolutely no pain whatsoever, just a little bit of cramping and discomfort. Obviously, so given that there was quite a lot of experiences, people talking about it online, I think it is easier because I put it in a GP surgery, so they're patients that I know. I've talked to them beforehand, we hold their hand, we thought it's all really nice and comfortable. It's probably a bit different when you're having it at a clinic where you don't know people, but the fact is it is still generally really good. For the great thing about Mirena, for some women, it just horrifies them, and that's completely cool. That's, if you don't like it, that's not right for you, and that's absolutely fine. For some women, however, it is brilliant because it stops your periods, which is great because sequential HRT won't stop your periods. Mirena stops your periods, it provides you with contraception, and it also provides half your HRT. So I've got a Mirena, which I absolutely love. It works for me. For some women, they absolutely hate it. Everyone is really different when it comes to hormones. So this is what I did say I'd go through this. This always comes out. So if anyone wants to know how to take Otrogestan, this I can tell you, I'm on a doctors menopause group, which I moderate. There are 1,600 doctors and we're about 50 joining every day. So things are changing. Everyone wants to know. This question comes up practically every day. And this is how you take it. So if I'm sure there are lots of people here who aren't taking it, so I'll just gloss over this, but this is how you take it. And the reason why there's so much confusion is because the licensed dose doesn't make sense. So menopause specialists don't give the licensed dose, they give the dose which we think makes sense. And that then obviously GPs just read the stuff that's in the book that we're all given called the BNF. The BNF doesn't make it clear, so they don't know what to do. So it's not their fault. This is just really annoying. The good thing is that if you're very sensitive to progesterone, you can take this vaginally. This isn't licensed, but a lot of menopause specialists do it. Some specialists say half dose, but I don't. That's a bit controversial. So, and then this is again, so I would say probably, just checking that my kids aren't outside, probably about 80% of the women that I see have issues with libido. And I think, and it's so common, and I think again it's something that we don't talk about, and it's something that doctors don't ask about, and it's something that is really hard in the context of a 10-minute GP consultation. I get 45 minutes with my new patients privately, and it makes such a difference. But there are loads of things that affect libido in menopause and perimenopause, and one of them is the fact that we're all so busy. Like, you know, everyone is juggling about a million different things, and then you have on top of this, you then have the fact that you're not sleeping. You might feel more anxious than usual. A lot of women, a lot of us gain weight, you put it on, you know, and you feel less attractive. And all of these things just make you really not. So this is the first stage of libido. So the first stage of libido is desire, and that is the psychological me wanting to have sex. And then you move on from that to arousal. So arousal is the physical wanting to have sex. And the problem is with that is that that is also affected by menopause, because when you have a lack of estrogen, you can get vulval and vaginal dryness, you can get pain, you get itching, all of those things. And so that makes people not want to have sex. And often now I see women in their 60s and 70s who've spent 10 years not having sex because it feels dry and it feels painful. And this is really, really easy to treat. But it's just, you need to see a GP who knows about it. And the treatment is vaginal estrogen, and this is really, really safe and can be given even to women who've had breast cancer. It doesn't go into the bloodstream. Often it's given at a too small a dose. So I work at Guy's at the menopause clinic there, and we give much bigger doses, and it really, really helps. By the consultant I work with there thinks all women should go on vaginal estrogen at 50 and just stay on it forever. It's brilliant stuff because it also really helps with your bladder. So it really, so again, estrogen receptors are everywhere. There's a lot of estrogen in the entrance to your bladder. And so for a lot of women will be like, my God, not only do I feel less dry down there, but my stress incontinence has got better and I'm not having to get up 3 times a night. And you're like, yeah, that's why. So often, again, it's really helps. A lot of women use the loose lubricants. The other thing is vaginal moisturizers, like yes. So again, as you moisturize your face, you feel your skin getting drier in perimenopause. There's no reason why you can't moisturize your vulva as well. And then the other thing is HRT is really good for a lot of women for libido. And the other thing is testosterone. So did I put a slide about testosterone? No, I didn't. So testosterone is again another thing that often comes up. So testosterone is a male hormone. It's what we associate with blokes, but it's also for women. And we have it in our ovaries. And the fact is, for a lot of women, especially, and this is especially for women who've had a surgical menopause, when they've had their ovaries removed, they immediately have nearly all their testosterone goes straight away. Now, some women feel nothing with libido is still great with absolutely no testosterone. And some people have loads of testosterone and their libido is terrible. And we just don't really know the relationship. But what we're using more and more now is testosterone, not only for libido, but also for fatigue and for joint pains and for anxiety. It can sometimes really help, but it isn't licensed for any of that. And they would be very lucky to find a GP who would prescribe it for that. Unfortunately, although it is because it's unlicensed and there are no guidelines, it is very difficult for GPs to know how to prescribe it. But hopefully they are coming. I've just read a paper today. I think it looks as if hopefully new proper guidelines will be coming out for GPs soon. And then the other thing is contraception. I won't go through this, it's really complicated, but the key thing is that, and again, this comes up all the time, you cannot use the progesterone-only pill or the implant or the injection as part of your HRT, unfortunately. So, and the other good things is, so it helps your symptoms, it reduces your risk of osteoporosis. So osteoporosis is thinning of the bone. So it looks a bit like that's the kind of crunchy bar. It's a diagram of bones. So osteoporosis is thinner, which is fine. You don't feel it at all until you fall over when you're 80 and break a hip. And hip fracture is a big cause of death among elderly men and women, especially women. So it's definitely something that is worth preventing. But again, it can also be prevented with exercise and with eating a healthy diet and getting enough calcium. If you start it before the age of 60, we know it reduces your risk of heart attack and stroke. It helps increase your muscle strength. It may reduce the risk of dementia. That's controversial and might do or might not. There's sort of jury's out on that. And it may reduce the risk of bowel cancer, arthritis, and depression. Again, there's not good enough trials yet on this. And then this is the biggie. So, and again, I'm sure many of you have seen Davina, so you know all of this. The fact is that we know HRT, actually we do know HRT increases your risk of breast cancer. It does, but so do a lot of other things too. So does being overweight, so does drinking a glass of wine a night. There are a lot of things that increase your risk of breast cancer. So, and this is where, so some women who are still being told by GPs that you can only have it for 5 years, this is where all this comes from. So when the big scare came out about 10, 15 years ago, that's what we were told. So we were told that we were only allowed to give HRT to women with debilitating hot flushes, and it had to be the lowest dose for the shortest time. So we know that it's actually now, we know it's not the estrogen that increases your risk, it's the progesterone. So it's the combined HRT that increases your risk of breast cancer. If you've had your womb removed and you're just on estrogen only HRT, it actually potentially might even reduce your risk of breast cancer. But this infographic is a bit out of date now, but the really good thing that it shows, if you look at it, is that in 1,000 women taking HRT for 5 years, 23 of them will get breast cancer anyway, whether they took HRT or not. An additional 4, or that is a bit an underestimate, it's probably about 4 to 8 women on combined hormone replacement therapy, slightly less potentially on women with estrogen only HRT. But the key thing is to look down at the additional cases in women who are overweight. So if you're overweight, this doubles your risk. If you've got a BMI of over 30, it doubles your risk of breast cancer. And so what I say to women is, if you feel better on your HRT and that enables you to exercise, and we know that if you're tired, you eat more rubbish. So if you eat more healthily, you start eating better, you feel better in yourself, you are going to be reducing that risk. And the other thing is that you've got to also balance your risk of hip fracture and the risk of heart disease as well. In terms of family history, I've asked about this all the time, but most breast cancers are not genetic. That's the other thing to note. If your mum had breast cancer in her 50s or 60s, that is not a genetic cancer. If the whole of your family every woman in your family got breast cancer in their 30s and 40s, which is unusual, that is when you need to worry about a genetic breast cancer. But by then, usually if you have a family like that, you've already been thinking about this, you've been to some genetic counselling, or you've been talked about this. So we do see women all the time who are at very high risk of breast cancer. And for that, we just need to talk about the pros and cons for you personally of increasing your risk. But the good thing to say is, for most, breast cancer is a common cancer, unfortunately. So for most of you, if you have a family member with breast cancer, that doesn't mean you absolutely can't take HRT. So there we go. So that was like the whole of HRT in 20 minutes, whole of menopause in 20 minutes. These are the really good. So Women's Health Sussex is my website. There's not much information. There's a bit of information about menopause and stuff on there, but the Menopause Doctor, as we know, is the best one. Women's Health Concern is really good, as is Menopause Matters as well. So there's lots of information on all of those as well. So there we go. And so that is my website. And then that's my Facebook page as well. So I put lots of information on there, lots of articles about menopause and discussions and that kind of thing. So excellent. All right. I will stop sharing my screen. Brilliant.